Good evening, everyone. I'll be presenting a case report of non-arteritic ischemic optic neuropathy after an acute attack of primary angle closure glaucoma. So a 63-year-old male patient presented to our OPD with chief complaints of blurring of vision, redness, and pain in his right eye. 4 to 5 days back, he had presented elsewhere and was diagnosed as a case of acute attack of primary angle closure and was treated with IV mannitol, topical pilocarpine, oral acetazolamide, and he was started on topical brimonidine timolol combination. When he presented to R, and the intraocular pressure recorded then in the right eye was 44 millimeters of mercury, in the left eye it was 34, and in systemic history, importantly, he is a hypertensive patient for the last 15 years, being treated on oral antihypertensive agents. When he presented to our OPD, the visual acuity in the right eye was 660, and in the left eye, he was having 6/6 vision. The right eye pupil was pharmacologically constricted since he was still taking topical pilocarpine. The intraocular pressure was maintained at 16 in the right eye, left eye was 18. On gonioscopy, the right eye 360-degree angle closure, and the left eye there was 270 degrees of angle closure. So he underwent both eye YAG-assisted peripheral iridotomy and was asked to follow up after 1 week, and the topical brimonidine timolol combination was continued in both the eyes. After 1 week of follow-up, the patient complained of further blurring of vision, and he was complaining that he could not see objects on the floor. So his visual acuity in the right eye had reduced to 1/60, and he had an inferior visual field defect seen on confrontation test. Color vision, only the test plate could be seen in the right eye. Right eye also showed a relative afferent pupillary defect. The intraocular pressure was maintained at 18. On dilated fundus examination in the right eye, there was optic disc blurring that was seen, and of the temporal and the superior disc margins, and a small splinter hemorrhage could also be seen. Left eye, he had a relatively small disc with a vertical cup disc ratio of approximately 0.2. He underwent a fundus fluorescent angiography, and in the right eye, it was seen that there was a filling defect superiorly and temporally in the early arterial phases. So on basis of all of this, we made a diagnosis of non-arteritic ischemic optic neuropathy, and he was started on oral steroids with tapering of the dose. And after 6 weeks, the visual acuity in the right eye improved to 2/60 with maintenance of the intraocular pressure. The optic disc showed a complete resolution of the edema with an eminent pallor. So this is a comparison between his first visit and after 6 weeks. To discuss, NAION is presumed to be due to a result of hyperperfusion within the optic nerve head. So if there's a sudden rise in the intraocular pressure, that can cause a reduction in the perfusion pressure of the optic nerve head, leading to compression of the vessels, leading to NAION-like picture. The blood supply of the optic disc and the peripapillary choroid have been shown to be the most susceptible to be obliterated by the elevated IOP. And the blood flow to the optic disc is determined by mainly the resistance to flow and the ratio of the perfusion pressure. Resistance to flow can be affected by, is affected by the vascular autoregulatory mechanisms, which can be affected by systemic diseases like hypertension, diabetes, and atherosclerosis. The perfusion pressure can also be affected if there's a sudden rise in the intraocular pressure. So to conclude, considering that the incidence of primary angle closure with reports of ischemic optic neuropathy is quite scarce, so there could be other mechanisms involved in this particular pathogenesis. And patients who are presenting with a primary angle closure, having an RAPD, a large amount of optic nerve edema, persistent decrease in the visual acuity, and a small cup to disc ratio in the contralateral eye should raise a clinical suspicion for NAION after a primary attack of angle closure glaucoma. Thank you.
So when the eye pressure is going up, the chances of CRV or vascular occlusion is far more than affecting the optic nerve and the
Yes,
circulation is from posterior. So primarily you'll end up seeing those cases more. But that in turn has an ischemic operant of the optic nerve, which doesn't fall in our typical category of the NAIONs that we talk about.
Yes, sir.
The mechanism of action is the same. So what is the kind of eye pressure beyond which, if it's rising, that one should start getting worried about vascular occlusions?
30 millimeters of mercury.
Yes.
Yeah.
If it's going beyond 30, definitely you need to treat it.
Yes, sir.
That was venous pressure.
Is also going up. Yes, sir. Thank you, sir.